After neoadjuvant chemotherapy, especially for patients who had a lot of nodal metastases, the concern has been we don't know what's going on with the axillary lymph nodes. We don't know if for sure all of the lymph nodes are responding in the same way or if some of them still have nodal metastases. So there was always a concern that we had to remove all of the lymph nodes just so we could have the most accurate staging. And that's key because a lot of our staging determines what other treatments the patients are going to get. And recently, we found a lot of data that shows that it may not matter whether you have 1 node or 4 nodes or 3 nodes. And we use that information generally just to figure out what adjuvant treatments the patients may need, whether it's medications, additional chemotherapy, immunotherapy, and certainly we use it for radiation. But the specific number of nodes beyond 1 node may not be that important, and that's what we're talking about in this talk. It's really important that we minimize morbidity for our patients. Lymphedema becomes a lifelong problem and it's very difficult to manage and treat. And so we've been doing everything we can to get away from doing a complete axillary lymph node dissection. And when we do a complete axillary lymph node dissection along with radiation, that's when we see the highest rates of lymphedema. So what can we do to decrease that? One of the ways is by downstaging the axilla, which is what all the neoadjuvant treatments are for. But if the patient still has residual nodal metastases, even after all of our efforts to downstage with systemic therapy, can we just do radiation or do you still have to do an axillary lymph node dissection? Most of the data are showing that for small amounts of residual nodal metastases, radiation alone may be sufficient, and then you can overall decrease the rates of lymphedema for these patients and obviously also avoid the nerve damage and some of the other issues that come with a complete axillary lymph node dissection. Yeah, no, that is really the data that we're looking for. And the concern is that if you have a poor response to the chemotherapy, as in the tumor doesn't shrink that much, you end up with at least 2 nodes positive, then how many more nodes beyond those first 2 sentinel nodes or first targeted axillary dissection nodes still have cancer? And if it's a bunch of nodes, the concern is that the radiation alone may not take care of it. And that's what we're hoping with this A011202 trial to determine. What's concerning about that trial, and one of the things that we need to keep a very close eye on, is that about 15% of those patients had 4 or more positive nodes. And all those patients received radiation. So the question is, if you have that much residual nodal metastases, and this is a randomized trial, so that's the 4 or more positive nodes is in the axillary lymph node dissection group, so you can presume the same in the other group. If that is what we see, then the local recurrence rate in the long term in the axilla may in fact be higher, in which case we should consider doing axillary lymph node dissection in those patients who have a lot of residual nodal metastases. Yeah, so ideally, we should be able to tell how many more nodes have cancer just by either looking at them or running a scan on them. If you could do that, then you wouldn't need to remove them. Obviously, we're not there yet. So I think what we're going to have to do is figure out which patients are at highest risk for having additional nodal metastases, reserve the axillary lymph node dissections for those patients, and give radiation to most of the other patients.